afternoon, everybody. Hope everybody is doing well. My name is Paul Manessi. I'm with Loma Linda University Medical Center here in Loma Linda, California. I am actually going to be taking the place of Mike Mersick, who is going to be out today for today's meeting. He's our Inland Chapter President, so I'm just kind of holding down the fort for him. Glad to see some of y'all here today. It looks like some familiar names and faces. We have a really good presentation for you guys today. For people that haven't run into this in the healthcare world, wipes and pipes, they do not mix very well. So we got some information on that, some possible workarounds if you guys are looking forward to that, and best practices and stuff that we've learned the hard way. Hopefully we can help some other hospitals maybe learn the easier way and work through that. As far as our inland chapter updates, we are looking currently for some locations to meet in person. If anybody here locally in the inland chapter area would be willing to host, please let me know. I'll put my email contact in the chat box if you guys are interested, or if you're just interested in joining us. We're trying to get set up maybe in June or July for an in-person meeting here at our hospital. So some more information will be coming out about that probably the next few weeks when we get the details worked out, but definitely looking to see who would be interested in meeting in person. I know a lot of folks really enjoy meeting in person. We've been away from it for so long. We're trying to get that kick-started again. Not to say that Zoom isn't great, but not every meeting needs to be in Zoom, and we're trying to move back in person. We also have requests out for any future projects. So anybody here in the inland area or abroad outside of our area has any suggestions for things that they might want to see, or maybe information that they're a little light on, or want some questions answered on, please let us know. We're happy to take suggestions from the team and help facilitate that in any way that we have availability to. So again, just shoot me an email. We're happy to move that forward for you guys. We are doing an in-person meeting, which will be our next golf tournament, actually. And I believe it is scheduled for October 11th. Registration will be coming out here in the next few weeks. So if you guys haven't played in the inland chapter before, we do it at Hidden Valley in Norco. Beautiful course, always really fun time. So if you guys aren't already part of that, the registration will be coming out here soon. So we're happy to be able to see most of you guys, or as many as we can in person, play a little bit of golf. And then as far as admin updates for CSHI as a whole, we are still looking for MEC presenters. So we've sent out a few emails the last few weeks regarding the MEC program. It's a really strong program, a lot of good information there, but we are looking for anyone that might be willing to present a topic. So if you've seen those emails, or if you have any questions about the MEC program, please reach out to, you can reach out to me or Beth as far as any follow-up questions on either possibly presenting, or if you have any questions or want to join that program. A lot of really good information for the management teams out there in the hospitals, and especially even for the technicians and supervisors. A lot of good stuff for that team as well. And last but not least, our 49th Annual Institute is in a few weeks right now, actually June 1st through the 3rd. So if you guys haven't already bought your tickets and reserved them, please do so now. If you guys have any questions on that, Beth is on the line here, and I'm sure she could touch base on it, or you can shoot her a call or an email. We got a pretty good turnout, it looks like, over there already, Beth, but we want to see if we can get any more last minute stragglers to join us. A lot of really good information coming out on that institute. If you haven't already looked at the venue, Squaw Creek, beautiful location. It's going to be a lot of fun. So if you guys aren't already part of that, please feel free to join us over there. With that being said, we have Dwayne Anderson, and he is with Stryker. He's here to present to us the pitfalls of what happens when you flush wipes down the toilet, and some of the solutions that you might be able to look at for your hospitals. So Dwayne, I will pass the meeting over to you, and if you wanted to screen share, we can get you going. You're muted, Dwayne.
Thanks, Paul. Let me grab the screen real quick. Okay, hello everyone. My name is Dwayne Anderson. I am a sales rep for a company called Sage Products. And actually we were purchased by Stryker a few years ago. And some of you guys may be familiar with our products. And actually when I'm talking to facilities or maintenance people, it's usually because there are plumbing issues. And a lot of times our products are kind of thrown in the bucket of products that are to blame. We have a flushable wipe. So really, I wanted to go through kind of some solutions that are out there in the industry. And then at the end of the presentation, if you guys had any questions, you can follow up with me individually. I don't know if everyone on here is Inland Empire. I cover the full Inland Empire, but if anyone is from outside the Inland Empire, there's other reps that are kind of covering the territory. So this is probably a topic that you guys are all very familiar with. So I put together a presentation and I pulled out some of the product specific information and just kind of put some other images in there. And when I was doing some research, I'm like, what am I going to show these guys? And I came up with these images, and I'm sure this is kind of one of your worst nightmares, having a main line or a pipe break somewhere in the hospital. Obviously that's shutting down rooms, causing a big catastrophe, and the end impact is the financial consequence. I think from my perspective, personally, two of the instances that I've heard of that are probably the most catastrophic is one was a leak over an OR suite where the actual leak happened on the OR table with a patient on it. And the other one was a leak in the OR, the sterile processing room. So they had to throw everything out. And I think that was over $1 million spent. So sometimes obviously the problems might not be as big. It might be local to a room or something, but sometimes it can obviously be very catastrophic. And these are some of the products that are causing the problems. Obviously, there's more than this. The flushable wipes or non-flushable wipes, doesn't matter. A lot of the nursing staff actually will dispose of both at times. Washcloths, I've even had, I don't know if anyone from Eisenhower is here, the old facilities manager. He told me a story of a disgruntled employee that was actually flushing, cloth products down the toilet. So those are obviously a culprit as well. Not toilet paper, but paper towels, something obviously that should not be flushed. It's non-dispersible, and also any other product that is non-dispersible, like feminine hygiene products. But really, as far as this presentation is concerned, I wanted to focus around the cloth, flushable and non-flushable cloth products, because really that's the product line that I carry. This is not my product. This is actually my competitor Medline. So this is a flushable product. And ours is non-flushable. We're very strict about that. We don't want anything flushed. Medline did it because they thought it's, will increase sales. And they don't have a readily available, I would say, solution for preventing clogs. So they thought the best way was to actually label their product as flushable, even though it's non-dispersible. If you've ever stuck it in some water and let it sit over time, it doesn't break up as toilet paper does. Really, the backstory, it begins with basins. We've always had products like, obviously washcloths and feminine hygiene and paper towels. Those have always been there. But the big thing probably in the last, I would say, decade or so that's changed is the wipes, really, and it has to do with the basins. Basins are a proven link to hospital-acquired infections. Obviously, we're in a hospital environment, so that's the main thing that we're looking at, is trying to prevent harm to patients. So we have tons and tons of studies showing how basins basically infect individuals, and it either deals with patient mortality and a increase in hospital stay, and then hence a reduction in hospital reimbursements and payments. And that's kind of my main target, is talking to the clinical staff, trying to, obviously improve patient outcomes. But obviously with that comes some complications with the wipes and the pipes. So we're kind of multifaceted, so I have to be able to flip hats and be able to talk to you guys as well about how to prevent some of the issues. Why basins are a problem? They're used for general bathing and cleaning, basically. And really, when you're cleaning the patient, that's where a lot of the MDROs or multi-drug resistant organisms live, is on the patient's skin. Another big issue is cross-contamination. If you guys have ever kind of noticed when you're walking by a room, a lot of times the basins will be stacked up on each other. And nurses don't really know, was that used for an incontinent cleanup? Was that used for a nemesis? What was it used for? So there's a lot of cross-contamination that can happen, hence making the patient at more risk for cross-contamination of any MDROs. And also the water system, that's something that we look at. Pathogens can create biofilms in the hospital pipes, and you guys are kind of up your alley as well. So a lot of the hospital water systems sometimes are contaminated. So really, about 10, 15 years ago, we were the ones that started the whole prepackaged, incontinence cleanup. We have prepackaged bathing. We have the CHG impregnated cloth. That was our company that kind of started this whole movement. Now a bunch of other companies, Medline, Chloroplast, and others, Coloplast, sorry, have joined in. So really, it's an exponentially growing market. And as I discussed, basins are a proven link to HAI. So we've done a huge study of 1,000 basins from 88 hospitals across North America. And we found that 2/3 of the basins studied harbor at least one pathogen commonly associated with an HAI, including MDROs. 62% of the basins were contaminated, 35% were colonized with VRE, 45% were colonized with gram-negative bacilli, and 100% of the hospitals in the study had at least one basin that tested positive for bacteria. Just one of the issues is CAUTI. That's probably one of the biggest things that my facilities are looking at right now, especially after COVID, is increase in CAUTI. In CAUTI, it doesn't, UTIs out in the public world don't sound that bad, but in a hospital setting, they can lead to secondary hospital-associated bloodstream infections, which can be, very harmful to the patient, even can cause mortality. And it's estimated that 17 to 69% of CAUTIs may be preventable. So the basin is one thing that we're doing to try and reduce CAUTIs. There's other things that are kind of out of this discussion. But really, one of the things that when a rep comes into a hospital, we're trying to make sure that they're doing the best practice as far as the clinical is concerned, and that is removing basins from the hospital. But unfortunately, the solution, it is bringing in prepackaged bathing. And we realized, obviously, after we implemented these products, that it was causing an uptick in potential clogs and floods in the hospital. So we have a product, and there's a couple out there on the market. But really, it's not just the product. There's other things that go around to preventing these clogs. But examples of the prepackaged cloth are the rinse-free full-body skin cleaning and moisturizing, one-step incontinence cleanup and barrier protection, and dedicated meatal cleaning, and that's for the Foley catheter. And there's a ton of support for the cloth-based products. IHI, WCN, APIC, and CDC, those are member organizations nationally, in which you guys probably are not as familiar with, but the clinical staff is extremely familiar with all these guidelines and basically them wanting not to have basins in the hospital. This is just a quick, I'll flip through this. This is a quick pyramid of clinical evidence showing all the peer-reviewed studies and posters and presentations promoting the removal of basins. But with that, obviously, as I said, it comes the associated problem with cloth products and other non-dispersible items in the pipes. So that can be female hygiene, paper towels, etc. And flushing wipes leads to toilet clogs, which could become line backups and sewer line bursts, which will lead to room and unit closures, patient relocation, infrastructure damage, and infection control issues. And these are some of the clippings that our company took of, just various hospitals around the U.S. With the consequences of improper flushing, which you guys are very familiar with. And the issue doesn't stop at the hospital. I'm sure you guys are aware of this as well. It goes downstream, and sewer lines get blocked up, pump station motors break, and treatment plants stop. And there's obviously tons of instances in the, you can just Google it and see that cities are spending, hundreds of thousands or millions each year dealing with the white problem. This is an old slide. So this, I think we pulled in 2012. So I'm sure this has exponentially grown, and the kind of pie has shifted a little bit, but you can see industrial is 36% of the white market. And I would imagine that that's where we're falling into versus personal care, household, and baby. And this is just a graph. Again, this is from 2017, so we haven't updated this, but I would imagine now this is exponentially grown. So again, you can see the industrial, how big the market is growing with the prepackaged wipes. So why is this happening? It's a behavior issue. No one's held accountable in the hospital. It's hard to kind of pinpoint who obviously threw, a non-dispersible item in the, in the line, if it was on purpose or not. Education will continue to fail, out of sight, out of mind, basically, from the clinical staff. And it's reinforced, obviously, on the outside by consumer acceptance of wipes and the industrial promotion of flushable wipes, including ourselves. So we did a hospital survey, facility management. We found 636 maintenance calls a month is an average. 10% are clogs, and there's over 700 clogs a year. And then the clogs cost is obviously going to vary across the country, but in toilets, anywhere from 500 to 15,000. In the wall, 1,000 to 10,000. Seepage and burst, 50,000 to 250,000, and fines range anywhere from 6,000 to 25,000. And this is an instance we found illegal flushing will cost hospital 6,000 in fines. This obviously varies by county and state and city. And as I mentioned, by the way, Ready Flush. So that was a product that came out, I think it came out 3-4 years ago. And I have a lot of facilities that have removed our product line and went to Ready Flush. And if anything, it's caused more of an issue because staff feels that now it's okay to flush these wipes, which you guys are probably well aware. They're non-dispersible. They're not actually going to break down in the water. And they can cause additional plumbing problems because you've now changed the culture to make staff think that it's okay to flush the wipes. So flushable wipes are not the answer. These are just some headlines that we found in the paper. I don't have to beat a dead horse, but we know that flushable wipes are not the answer. So what is the answer? It's addressing behavior of staff and implementing protection devices. So our company, we do a lot of staff education. Primarily we're doing, let's say 99% of my education is on the clinical. But when we're doing education about plumbing, we educate the entire house on basically, I'd say methods and protocols that we've put in place to prevent flushing, so they're aware not to flush anything in the toilet. Putting visible signs in doors, so that's something that comes with our, clinical products. We have on the left, that's an actual poster of ours. On the right, I just had to find an image. But we have images that typically they'll go right where the flush handle is, somewhere in the toilet, on the back of the door. The no wipes in the pipes stickers, we usually put that again on the back of the doors and somewhere in the bathroom, just to kind of alert staff and keep it in the front of their mind that we do not want them flushing anything on the toilet. And really kind of the catalyst to everything, I would say the pinnacle and spearhead is a plumbing protection device. Without that, we can educate as much as we want. And you can put stickers all across the hospital. That's not going to really change behavior. You need something tangible to kind of really spearhead the effort. So a plumbing protection device is really number one in kind of this whole kind of shift of thought, if you will. So really the only thing that's going to work is a multi-focused approach, starting with protection at the source. So number one, some sort of plumbing protection device. Number two, obviously sticking signs and having, at the forefront of the mind, not to flush any kind of non-dispersible product. And three, finally, is staff education. And really this leads to a change in behavior. So fewer maintenance and plumbing calls, fewer clogged pipes, equipment failures, and plumbing disasters. It encourages staff, patients, and families to deal with the issue. And I forgot to remove that. And also we have a retriever that basically pulls the any kind of non-dispersible product out of the toilet neck. Here's an example of a facility. We'll just kind of look at the chart. There was 54 calls or flushing incidents in a 2-year span after implementing a protection device, educating staff, and putting up stickers. You can see that went down to 0. And that was a 2-year kind of follow-up after the fact. And just depending on where you're at and the cost and the kind of severity of the burst, the ROI can be varying. So thank you very much. It's pretty straightforward presentation. If you guys did have any kind of questions, you wanted to follow up with me individually, there's my contact information. You can give me a call or you can shoot me an email. And then we could talk offline about specifics about kind of a protection device and any kind of additional services that we can provide. So I hope that was relatively informative for you guys.
That's awesome, Dwayne. Is there anybody, and I don't see anything coming through on the chat, but anybody have any questions or comments for Dwayne or anything around the pipes? Well, we got him on the call here. See if I see any hands raised.
Okay, well, I'll flip it back over to you. So if you guys have any questions, you can always follow up offline. I appreciate your time, everybody.
Thank you, Dwayne. So just speaking from some personal experience, we had issues with these backups in our hospital. So we weren't that hospital that was on the graph there, but I had similar findings. So we had a hospital at some point that was dealing with these leaks over and over and over from clogs. To Dwayne's point, it's really a focused approach when you're trying to solve these problems, because staff education and leadership buy-in was a thing that really pushed us over the edge. I had to bring the financials to my leadership team and say, hey, this is what's happening. We're having these backups every 3 to 4 weeks in this area. It's costing me $50,000 a month just for restoration costs, downtime, etc. Can we get some support from the team in order to explain to the staff members that even though if it says it's flushable, do not flush it. It may work at home, but not here in the hospital. We also, and Dwayne, this is one thing that we learned when we added some stops in our toilets. We had to add some trash cans to go along with it. So the question became, all right, Paul, I'm here in the toilet and I have this dirty wipe. Am I supposed to walk out into the hall to throw it away in a trash can? So on top of the education, the signage, the leadership buy-in, we also had to install some little trash cans, little receptacles with a lid inside each one of our bathrooms in order to have someone actually, they got a dirty rag, they got to put it somewhere. And we wanted to make sure that was there available for them.
Yeah, and just to kind of add on to that, Paul, it is our job. I know, like you said, you had to present that big, kind of, nothing's moving forward unless you do that. So it is the rep's responsibility. If, the facility will need help with gathering that information. So we have all the back end support, the numerical data to kind of help you guys along with that. So you have enough on your plates. You don't want to have to pick up a whole new project. So myself or, if there's someone in a different area, the reps are fully geared to kind of help you guys out with that discussion. And then also have the clinical discussion with the, the executive team as well. So well, thank you very much, Paul.
Awesome. All right, everybody. So that'll conclude our presentation for today. Like I said earlier in the meeting, we are looking to getting back into in-person meetings. So if you guys have a location that you're willing to host an inland chapter meeting, please let me know. We're happy to get in communication with you guys and get that worked out. I'm looking at a possibility of doing it here in Loma Linda, either in June or July, as long as everything holds together for us. So you guys will see a communication coming out for that shortly. Hope to see you guys at the annual institute June 1st through 3rd. And then just as a reminder as well, October 11th is our tentative date for our inland chapter golf tournament. So should be a lot of fun. If you guys have any questions, feel free to reach out to me, Beth, Joyce, or Cindy from our team, and we'd be happy to see you. Cool. All right, guys. Well, thank you for your time. We'll see you next one.
Thanks, everyone.
Thank you, Paul.
Thank you,
Thanks,
Cindy.
Paul.